So without further ado, our presentation that stands between you and lunch, so be nice, is the role of behavioral health in medical health homes. And our presenters are Kathleen Reynolds and Mady. And I'm not going to read their bios because you heard them yesterday, but we brought back the dynamic duo together so that they can give you some additional information and start breaking down the overview that they gave you yesterday. So without further ado.
You've got to be wondering, what can she possibly have to say about integration? I've heard her so many times on this topic, but believe it or not, I have additional things to say. And it's just so important to me, and it's great to share this presentation with Mady. It's sort of like mental health and substance abuse coming together, and I'm not going to trip her as she comes up to talk, and you know, she didn't push me when I got up to go, and we're going to show you how we can work together very effectively. One of the people that I sometimes present with talks about bringing mental health and substance abuse and primary care together as being like peanut butter and jelly. We make a really good sandwich when we're together. And so peanut butter and jelly are up here to talk with you today about continuing to move forward with behavioral health services. Just a presenter nightmare. I was very relaxed this morning and was sitting out waiting for the first session, and I thought, well, I'm going to take a look at my slides for 10:45, and I open it up and I'm like, I don't remember using that cartoon a second time. I had saved the same presentation under 2 different names, and I'm like, holy moly, where's the 10:45 presentation? So found it, and want to talk with you a little bit about this. I mentioned this very briefly yesterday, is that our country really has a sick care system. We don't have a health care system. You know, we don't focus a lot on prevention. You know, the first thing to get cut is prevention, you know, all those sorts of things. So we really have a sick care system, and I think what we're trying to do, and I hope what we're trying to do, is really to get to a health care system that really pays people to be healthy rather than puts all the money into doing tests and finding out why we're sick or treating us after we get sick. So we really need to reframe the work that we're doing. And the only way to do this is to bring behavioral health into that mix in the healthcare system. As we mentioned yesterday, it's an acute care system. It treats people when they're sick. It's working on doing work around chronic illness and chronic disease, but that's in some ways our specialty and what we can bring to that group to move forward. So we have to do this for the work that we're doing. I want to talk about the 4 key strategies that the Affordable Care Act has. So one is insurance reform. Has the health insurance exchange started here in Maryland yet? Are you moving out on the health insurance exchange? Anybody know? I can't hear. I hear a voice telling me this. Uh-oh, I hear a voice. Where is it coming from? It's not just in my head. So there's a blueprint, and the name of the blueprint, you know the name of the document where we could see that?
If you go on to the DA website, you can follow the links to the health.
Okay, follow the links to healthcare reform on the department's website, and you can get the blueprint for the health insurance exchange. So there's going to be insurance reform, coverage expansion. Mady, I think, talked a little bit about that yesterday, and she's going to talk about the coverage expansion as part of her presentation for substance abuse. Delivery system redesign. There will be delivery system redesign. Sometimes when people talk about this, they talk about you can either be at the table in the delivery system design, or you can be on the table for delivery system design.
And get chopped up.
And get chopped up. So, yeah, so there will be, and I mentioned this yesterday, in DC, when folks want to agree, what they agree on is health reform, they agree on integration of mental health, substance abuse, and primary care, and they agree on health homes. And so we have to, and there will be delivery system design, and I think the question is, will you be out front of that, or will you be responding to somebody else's model going forward? And I always like to be out front and be at the table on that. And then payment reform. I can't wait for 2014 to have payment reform, you know, in terms of the work that we've done to make sure that this is billable now, but it's going to be critical that we have that done. So, here's what we know. Most primary care physicians do a good job of diagnosis and beginning treatment for depression. And this comes from studies that we've seen across the country. Notice that it talks about them doing a good job in diagnosis and starting treatment. The PRISM-E study, which looked at depression in primary care, actually found that primary care did a decent job of treating folks in depression, but when you looked at the actual outcomes of the folks that stayed in primary care and had their depression treated and the folks that went to specialty mental health in that study, both folks got better, but the folks that went to specialty mental health had even better outcomes than the ones that were treated in primary care. So primary care can do this, and they are advocating. If you go to national conferences, you have primary care leaders in primary care saying that they can do 80% of what we do in their clinics with behavioral health staff there. So primary care has already sort of put their stake in the ground and said, we can do this. And I know we were talking with the person who introduced us. She's a certified substance abuse program, hires her own behavioral health staff to do mental health and substance abuse, and it's an example of what folks are saying. We often like to say, well, they're really not seeing the folks that we see. They are. They are. They're seeing them every day. They're working with them every day. And so while we might say we don't think they can do that, that's their position, so we need to get into the system with them. They do less well in following up over treatment over time than us. The issues that go along with chronic care are managing a chronic illness, so that's why it's good for us to be in the primary care. And the lowest quality of care occurred among those with the most serious symptoms. Okay? Makes sense, we would know all of this, but we need to be talking about, right now, primary care practitioners don't have the tools necessary to decide which patients to treat and which to refer to specialized mental health care or substance abuse care. So our role, which is the topic of this conversation, is what's our role? Our role is to get in and work side by side with the folks in primary care and help them do this screening. Help them figure out who can be treated in the primary care setting and what needs to happen and who needs to be referred to the specialty program. Healthcare reform doesn't do away with our behavioral health services. In fact, it expands access to it in 2014 when we moved to the Medicaid reform. So it's not an issue of we're going to go away, it's where we practice and how we practice that's going to change. The service delivery design changes. We talked about this yesterday, the morbidity and mortality. There are folks with serious and persistent mental illness, and I'm going to talk about substance abuse too, to talk a little bit about this, are dying of modifiable risk factors. Only 40% of the early death can be related to suicide and homicide. 60% are related to things that if we got the folks that we serve physical health care, we could reduce their early loss of life. So one of the things, I think you've heard this, if you've heard me speak, I usually say this, 43% of the cigarettes are sold to people who have a mental health or substance abuse problem in this country. And 20% are sold to those of us who work with people who have a mental health or substance abuse problem. So that's really true. I'm not just making that up to get a laugh. But 63% of the early loss of life due to smoking is within our control as folks who work within the system, if we'll only do something about it. So we need to do something about this and have smoking cessation everywhere we go and be working on these kinds of issues with folks. Poor nutrition, obesity, living in a group home. One of the things that we often think we're doing consumers a benefit is getting them into an adult foster care home or into a group home. Don't know how many of you have had lunch or dinner in an adult foster care home, but the food is hot dogs, bologna sandwiches, macaroni and cheese. Because of the cost of food, it costs more to have fruits and vegetables and those sorts of things. So they're not doing it to be cruel to people that they're serving. It's a cost issue, and what you can afford to have in those homes. But when I worked at adult foster care homes, and we eliminated smoking in all of ours, but you would walk in and the first thing you would notice is the blue haze from all the smoke. And we've gotten rid of that by going non-smoking. And then we actually put advanced nurse practitioners, and this was able to be reimbursed, out in our group homes and started what we called a Healthy Home Project. Got people up and exercising, got people eating well, and those kinds of things. So we need to do something about these modifiable risk factors that folks have with this. So in the adult population, this is just a little chart that shows you that people with medical conditions are 58% of the adult population. It's amazing. I think one of the other slides I have, 45% of the people in this country have at least one chronic health problem, whether it's mental health, substance abuse, diabetes, or health. So half of us now. And the headline in the USA Today was about obesity, and that 45% of our country will be obese this year. Wasn't it this year? Yeah. So we've got huge things that we need to do. And I'm a part of this. I worked in the system for 35 years, have worked in the system for 35 years, and I can remember when I was a case manager, not only was smoking cessation not on the plan, we provided cigarettes as a reward for doing things. Right? I mean, that, token economies based on cigarettes, and, so I can't tell you the number of folks that, on my caseload, that I can remember some of them who died early of natural causes, and I'm like, wow, I was a part of that, and I think that's why I always have something to say on integration, is to let that not happen in the future. So, in substance abuse, this is a little bit where Mady and I may overlap, but we don't think we can say it too many times. Inhalant use, you know this, those of you who work in the field, and 12 to 17-year-olds is increasing along with depression. We've got to be doing work on that. Patients in chemical dependency programs are 18 times more likely to have major psychosis. And this is one of the huge issues I hear when we talk about bringing mental health and substance abuse together. And I worked for 30 years in Michigan, and I was on 3 committees to bring mental health and substance abuse together. Unsuccessfully, I might add, over 30 years, but we really tried. And one of the things that always came up, and I can remember hours and hours of conversation, is that and we were an integrated mental health substance abuse program, so I really never understood it, but I worked really hard to. But people would say, we're really afraid that if we merge with mental health, all we'll work on is comorbid mental health and substance abuse issues. That there would be no respect or no understanding that there are people who just have substance abuse issues. But there is, and we do understand that. And I think that's one of the fears as you talk about what's happening here in Maryland with bringing mental health and substance abuse together. This happened in our integration in Washtenaw when I took the mental health center to merge with the University of Michigan Hospital. People said, you're going to be eaten up and spit out by U of M. Why would you merge with somebody who's 10 times bigger than you? Well, we did, and it worked out really well, and we didn't get eaten up, and we actually became good partners with them. We have the same issue when we talk with folks who want to be in substance abuse, because oftentimes mental health is 10 times bigger than substance abuse, so just the way the funding is gone. And so you get concerned, when you sit down with the lion with the lamb, but it can happen. And I'm not suggesting that mental health is a lion. We're very nice. I am a Leo. But it really is possible, and it really can work, but it takes everybody to do this, to move forward. Substance abuse increases the risk for hypertension, heart failure, and pneumonia. We know about the issues with substance abuse and HIV, and then Medicaid patients and returning to the hospital within 30 days. Key issues. Other issues are it increases the rates of complications with hip replacements. I can remember when I was doing screening for substance abuse, I went to see a woman who was in the hospital she had like her 20th broken bone. And so no one had asked her what she was doing right before she broke all these bones. She was drunk. So I went in and, this really intense intervention, and I said, what was happening right before you fell down? She said, well, I was staggering. Well, what was happening right before you were staggering? Well, I was having my 10th beer. It's like, okay, I think we maybe figured out why you had 10 broken bones, And folks just weren't asking that. People were, putting the cast on and sending her home, and no one was taking time to just talk about why is this happening. So we need to get doing that in primary care and helping folks work on that. The high cost to folks, we know that our folks take about, the statistic is that about 20% of the consumers use 80% of the health care. Those 20% are the folks that we serve. They're the folks with co-occurring disorders. In our area in Michigan, when we started working with the hospital, we ran a data set. We found 8 people that were using about $250,000 worth of health care across the system every 6 months. They had a mental illness, a substance abuse problem, and diabetes or heart disease. And they were in and out of the hospital. And you know, the university was talking, and it was like, I said, for that much, we can have somebody live with them. You know, if you want to give us that kind of money, we can have somebody live with them and make sure they don't use, you know, and work with them around their recovery in a way that you're not. And so, important to do. 25% of healthcare patients report a substance abuse problem and physical problems that are related to the use of substances. So if you're wondering why we're here badgering you every time we get up in front of you about integration and getting into primary care, this is why. The folks we need to get to are already there. 1.7 million visits to EDs. So what would we do if we went into the behavioral health or into the medical home? You saw this from me yesterday. We need to get our services out of our silos and into the primary care setting in any way that we can. Last night at the reception, somebody came up and we were talking about they're just a few blocks from a primary care setting, and she was saying, so I could take one of my staff and put them down there. And the question was around billing. And so we worked through that billing issue, and it was like, I'm gonna go do that. And it's like, great. You know, one every time I talk is working out pretty good. So, but we're looking forward to that kind of partnership with folks going forward. We've talked about the Medicaid health plan option. If you're wanting to know what's our role going to be, which is the topic of this discussion, these are the outcomes that CMS expects from the healthcare home. Lower rates of emergency room use. If you look at the top ER utilizers in any emergency room, they're going to be folks with co-occurring disorders. Can show you 3, 4, 5 studies that show you that the top ER utilizers have a mental health and or substance abuse problem. So we're going to be working to keep people out of the emergency room by seeing them in primary care. Reduction in hospital admissions and readmissions. The biggest single issue someone is readmitted within 30 days is a lack of medication reconciliation. When someone gets out of the hospital, they've changed their meds, and nobody sits down and works with the person around what meds they're supposed to stop, what their new med regime is. So they take everything they were taking before, plus everything they got at the hospital, and they're back in the hospital within 15 to 30 days. So what can we be doing? When folks get out of the hospital, we need to be having med reconciliations, and this gets into a whole professional issue of should it be a nurse or should it be a social worker. I think it should be the person with supports, because it's the person who at the end of the day has to manage their medication. And so a social worker can sit down with the person and say, what were you taking before you went in, and what were the recommendations, and let's make sure we get this straight. And if there's any question, the person can call the doctor or the hospital to get that done. Would love to have it be a nurse. Joan King and I, you know, Joan's a nurse, and we're so grateful to have her now with the National Council, but we're never gonna have enough nurses. So we need to be getting this done in any way that we can get it done. Reduction in healthcare costs. When we did this integration of mental health, substance abuse, and primary care in Washington County before I came to the National Council, we started in 2001 with our first cohort of patients. We reduced their medical costs 20% by 2003. Now, we increased their behavioral health costs, but we reduced their medical costs. And the hospitals were willing to pay us for that, because we still, even with the increased mental health and substance abuse costs to provide that treatment, the total cost of care went down 20% in 2 years. Now, when we started a project, we did not say that we would have any cost savings. We said we'd have improved quality of health care and improved outcomes for consumers. That we got cost savings was wonderful, and it really helped our project, but it was not necessarily our goal. But that's what we found, and we not only improved quality, we reduced cost over time. Long-term care facilities, you know, we want to reduce our need for long-term care facilities and have people treated out in the community. We're experts at that in mental health and substance abuse. I'm not sure about Maryland, but I know in Michigan we have almost no residential program now for substance abuse. Everything is done on an outpatient basis. I can think of only 2 residential treatment programs we have, so we've moved from the long-term care to community-based outpatient services, both in mental health and substance abuse. In Michigan, we have no hospitals for persons with developmental disability, no state hospitals, and we have 1, 2 hospitals, public hospitals for people with serious and persistent mental illness. So long-term care facilities, you know, Olmsted did away with people being in nursing homes, and so we're moving to that, and we're experts at this community living aspect. And then obviously improve the experience and the quality of care. If you ask your consumers, would they rather have care in a separated, segmented behavioral health system or in primary care, 90% of them will say they want integration. For the health homes, this is really important to know. If you pursue the health home amendment that we talked about yesterday, you can have a health home for a person who has only a serious and persistent mental illness. So we can develop health homes. That's why you see a lot of them out the gate being related to serious and persistent mental illness. That's the only issue they need. The chronic conditions do include substance abuse disorders. But if you're not working with people with serious and persistent mental illness, you have to have 2 of the chronic conditions. So asthma, diabetes. Mady's shaking her head.
That's easy.
Huh?
That's easy.
That's easy. Yeah, I was just going to say, it's very rare that we'll have somebody who doesn't have an issue with that. We talked about the 6 services yesterday, and I mentioned to you the states that are doing this. If you think that folks are sitting back and waiting, they aren't. You know, here's 6 state plans have already been approved. There are 4 states that, well, actually I should have changed that to 3 because this slide changed. Oregon was submitted, but they were approved, so I should have done 3 state plans that have been submitted and are awaiting approval, and then 15 states with planning grants. So we've got 19 and 6 is 24. Hey, we've got half the states now involved in the health home work. So even, and folks say, well, I'm going to wait and duck until they decide on the Affordable Care Act and whether or not it's legal. This is going to continue even if the Affordable Care Act gets overturned by the Supreme Court, or even if it gets pulled back as a result of the election. This work is not going to stop because people are going to see cost improvement and they're going to see quality of care improvement. So this is the slide I ended with yesterday too. I just can't emphasize enough that you don't have to start from scratch, that there are models across the country. As I mentioned to you yesterday, Mady and I and Aaron Williams, who a number of you know, hosted a meeting with innovative substance abuse sites from across the country in Chicago in April. And we have models across the country of folks who are doing this integration. They're bringing primary care into their site. If they're an addictions provider, they're going into primary care sites. They're creating health homes. They're bringing mental health in, and they're just having great peanut butter and jelly sandwiches all across the country. So I'm hoping, and I get one more shot at you today in a workshop where we're going to talk about organizational readiness, but I'm hoping that Mady and I have been able and are able to talk with you about how important it is the minute you leave here to begin partnering with somebody to move forward with health homes. So I'm going to turn it over to Mady, and then we'll take time for questions. I didn't mean to keep the clicker.
It's just about power.
So a little different, a little different take on the whole issue of integration at a very much ground level, and paradigm shift. You can see this paradigm draft, paradigm drift, paradigm finally shifts there, you know? That's where we need to go. I want to say, before I get into the presentation, one comment about HEDIS. Those of you who didn't know what it was, there are 2 measures in HEDIS that have been adopted for substance use disorders, and all health plans are using them now, every single one in the country. One is about initiating treatment, having been identified as somebody who needed treatment in primary care, initiated and engaged. And if you will remember, there was a slide yesterday where I talked about what SAMHSA says the good and modern system includes, and you saw engagement services. When I was listening to Patrick this morning, I thought, how many folks in this room are thinking about how to engage patients so they come back for the next visit? We know what the dropout rates are. I don't need to talk to you about that. So there are a few new words for today when we talk about immigration. Work at the top of your license. I don't know how many of you hear these kinds of phrases. Work at the top of your license. Become part of an interprofessional team. Be a high reliability organization. I'm going to talk to you about each of these in a minute. Do the 5 A's and the 6 T's. And monitor, if you're on a team and everything that's done in integrated primary care settings is done with a team. Know what the rest of your team members are doing, and monitor it carefully so that you can jump in at a moment's notice. One of the things we heard in Chicago from the people who are a step ahead in doing integrated care is any old time I can jump in for the other person on the team. And it's a very, very different way of operating than most of us in specialty care are used to. It happens quickly, and you have to be ready to move. And you need to know what the other person is doing. So you can read this yourself. It looks at where we are, where we have been, and where we're moving. Particularly note treatment gap reduced and easier access. I talked about that yesterday. I know Kathy did as well. And Patrick did this morning. So we keep hitting you with the same issues. There are a lot of forces for integration. I think you've heard them all. I don't need to repeat them, except to say that somebody mentioned this morning in the questions, are we going to reduce quality by doing things with computers and doing things more rapidly and efficiently? And let me say that we know now there is sufficient research, we don't need any more research, on whether screening and brief interventions are effective. They are effective for what they are. They're not effective for what they're not. It would be good if we knew the difference. It would be nice. Use of medications is effective. There is no question. We don't need, I could show you slide after slide after slide on the effectiveness of medications. And everyone in this room should be aware that it's at least 20 years ago that Myrna Weissman, who was a researcher at Yale University, produced all of her papers after major clinical trials on what were the most effective treatment for depression. And what was the most effective treatment for depression? We all should know this. A combination of psychotherapy and medications. What is the most effective treatment for substance use disorders, despite some folks still wanting to say, I'm an abstinence-only organization? Medications and various cognitive behavioral therapy or motivational interventions or a variety of other psychotherapies, which is how I think about it. Kathy talked about this. So take a look at what helped Washington State move into that list that Kathy showed you about states moving ahead with state plans. They did their own analyses to see who their Medicaid expansion clients would be in 2014. Take a look. And how many of them, I mentioned this yesterday, will be coming from the criminal justice system. I know you heard about this yesterday, but you need to think about it. And you need to think about what the implications are of this, and whether, indeed, these are the same clients you're currently seeing or not. Because they may not be. I mean, just because somebody is criminally involved in one way or another doesn't mean they are a seriously addicted person, as you may be aware. I'm sure you've seen this slide at least 50 times in various presentations. Coordinated, co-located, integrated. You don't have to when you're thinking about integration. And we heard this in Chicago, and I've heard it at TRI, where I work. Also, from programs, you can start at the even talking and move to co-located and move to integrated. You don't need to start and say, okay, I'm just going to get integrated tomorrow. So I said I'd talk to you about the 5 A's. The 5 A's were created numbers of years ago. 2002 actually is when this was published. Assess, advise, agree, assist, arrange. Keep it in your head. Routine assessment, advise patients that their behavioral health problems, this is in primary care, are important to their health care. The patient and clinician need to be on the same page. Helps. Assist people with self-management, problem-solving, coping skills, recovery supports, referrals. You're assisting all along the line. And I heard some, there was another comment when Patrick was talking. He was talking about the outcomes. Yes, there's the SAMHSA, NAMS outcomes, and GIPRA, and this and that, and the other thing. And TEDS, which includes the outcome that has been the most difficult in everybody that I've talked to deal with, which is discharge. Well, if you've got a chronic disease, do you get discharged? No. No. You see your primary care doc, and you keep going back, and he tells you how often. I mean, I have back problems. My rheumatologist says, once every 4 months, I want to see you. Okay. I know what I need to do in between, and once every 4 months I go for a visit, and he, by the way, is completely electronic. Completely. They have a large group practice in Washington, D.C., 15 rheumatologists, all board certified. Every single one board certified. They send you your materials online. And they take all the insurances, by the way, including Medicaid. They send them to you online, and they say, print them out and fill them out. You don't have to do it online if you don't want to, but print them out and fill them out. Do not, and it says right there in bold letters, do not expect to come to this office and have us give you the paperwork here, and you're going to sit in the waiting room and fill it out. Fill it out and bring it. And they input it, and then when he comes in to see me, he walks in with his little computer. And by God, he actually has some skills. He can do 2 things at the same time. He can look me in the face and do an interview and he can actually put the computer down and examine me if he needs to, and then go back to the computer and input what he needs to. Why do I tell you this? Because rheumatologists, arthritis people, are all at the same point that we are in mental health and substance use disorders. Why do I say that? Think about their outcomes for a minute. Think about what they're up against in trying to figure out outcomes. Their outcomes range from, I can hold a cup in my hand, I can stand up, I can sit down, I can dress myself, I can walk 2 feet, I can walk a mile, I can work a few hours a day, I can get up to a sitting position from lying down. And we are talking about here about, oh my God, how am I going to figure out an outcome? Well, guess what? When I walk into his office, he says, I'm only thinking about one outcome: functioning. You can live your life and do what you can do. And it seems to me, NOMS, TEDS, GIPRA notwithstanding, where we are going are the things that Kathy showed you a minute ago, and to function. That our patients have to be able, and we have to assist them in managing their own problems, coping as best they can, getting to recovery supports, and being able to live a life. So what are the 6 T's that I talked about earlier? The 6 T's are barriers that in research various people have said, gee, I don't know if I can do this. Why? I haven't got enough time. I don't know what to do with this as primary care. I don't know what to do with a positive screen. I have just too many things to do. Look at the big ones: triage competing problems and lack of treatment resources. What can we bring to the primary care system to solve those problems? Those are the problems they say are barriers with regard to substance use disorders. We can bring something. I think we can. We know that there are plenty of barriers to medication, use of medication and treatment, and I myself don't particularly like medication-assisted treatment as a title, because we're the only people in the world who talk about assisting treatment with medications. Nobody else does. Diabetes, you use insulin, it's a medication. Even with psychosis, you use a medication as part of comprehensive treatment. You don't assist your treatment with medication. But anyway, there's lots of issues related to people getting comfortable with this. We are at the cusp of a new era, but people are going to have to begin to get more comfortable than they currently are. So we can't just drop what we're doing, to integrate, but we do have to start to shift our focus from the individual to our target populations. We have to use brief, focused interventions, particularly in primary care. We need to start thinking now about workforce issues, and you've heard it quite a lot about them, but you need to continue to focus on them. And we need to think about, as we're talking about integrated care, we need to talk about after-hours coverage, and I don't know how many people are going to think about that issue. All the questions we need to answer about workforce and about preparation, and I want to show you a couple of things. The skill set that we need in terms of interpersonal skills and quality improvement skills. Patrick talked to you about use of data this morning. communication, conflict resolution, and teamwork skills are something that a lot of us who are doing workforce development are focused on. Because that's not the norm in our specialty treatment program at all. The norm is not teamwork. The norm is I'm in my office or I'm in my group. So if we are going to move toward integrated care and try to function in primary care settings, we're going to need new skills. How many of you have ever seen this? I hope for those of you who are substance use providers in this room, it's a bit shocking. These are state-level requirements for credentialing for mental health and substance use disorders. For those of you who are substance use providers, we need to get on this. This cannot continue. I'm not going to go through this. You can see what's highlighted here. Interesting to me that case management is more required for a substance use counselor than it is for a mental health counselor. Health issues and diseases, courses in health issues are much more required for substance use than for mental health. But look at measurement, research, and evaluation. Good Lord. So what's a high reliability organization? Few mistakes, long periods of time, consequences of mistakes are serious. And in our fields, they are serious. And Kathy talked about the mortality and morbidity for serious mental illness. We know what the issues are for addictions. And, you know, I don't need to go through the whole list. We also know that effective teams are critical to a high reliability organization, which is what you want to be. You want people to be able to count on your treatment services. And these words, these new titles, I'm sure you've heard them, they're floating around everywhere. But they all have to do with people functioning in healthcare settings. A consultation liaison, I don't know how many of you were around. I was. When consultation liaison psychiatry was a big deal, I did some of it. I liked it. It's back. And it's not just consultation liaison psychiatry. The American Society of Addiction Medicine is getting ready to launch a year-long project with physicians on performance standards for specialty docs in any setting, including in primary care settings. And that means consultation liaison. Think about how you're training folks with regard to screening and brief interventions. All expert is not created equal. Saying to somebody, hey, you have a few drinks yesterday is not a screen. So all expert is not created equal, and if you really want it to work, if you care about it, people need to be trained properly, and it's not impossible, and it's not all that difficult. Oh, and by the way, National Institute on Alcohol Abuse and Alcoholism is just finishing a study where they created a screening and brief intervention for physician app for a smartphone, where there's a little avatar inside it. And the physician can download the app and take it home on a smartphone, his or her smartphone, and hit this thing, and the avatar is a patient. And they do a screening and they do a brief intervention and it prompts them and the avatar responds and changes and as they ask the questions, and it gives somebody, a clinician, this could be for anybody, an opportunity to do this at home, out of the sight of everybody, and practice. Okay, I think I've got 15 minutes, I think I'll practice. Which is what we want people to do. We still have some, we're moving slowly but surely to financing changes. We still have some things we need to fix. We've got problems with same-day restrictions, same-day billing. I'm sure all of you know about that issue. Contracting with the lowest cost provider, great. And we need more work on facilitating the billing changes. I don't need to remind you about all of this. Lots of things that need to change. Thanks.
So you've had the opportunity to hear Mady and I twice, and I think it's pretty clear where we stand on this. Would love to engage a little bit. I know this is even worse than last night when you said, you know, we were going to eat while we're talking. They're setting up while we're talking, so the pressure's even on even more for us. But what are you thinking about what you're hearing? What do you see as some of the opportunities? What do you see as some of the challenges from your perspective? And I'll do my red, white terms letter. I forget who runs the microphone. I'm happy to run the microphone around to get you to talk. But what are you thinking? Hold on, let me. We'll come on down and, oh, that's the game show too.
I noticed that Maryland was not anywhere on the list of states that is either working on approval for anything. So what is happening here with that, and how do we become involved?
Do we have some folks here that can answer that? You actually have a lot happening. I'm amazed at how many consultants that you have and folks who are working, and there's everybody, you've been voluntold to answer that question. Everybody's pointing to you. So let's hear what's happening here in Maryland.
I'm Danya, Maryland General Assembly. Right now there are several different groups, many groups working on integration of care with a target of the end of September to be able to go to the legislature by December, pre-file something so that we can move forward with it. And there are a number of different websites available. Most of it's going to be done through web-based and then additional work groups. So that's briefly in a nutshell what we're doing. There is a lot going on, so we are moving forward.
I have a copy of a report from Maryland that recommends an integration model that came from a consulting group out of Delaware that is available for folks.
I'm sorry, I had this in my notes. There are 3 different models being looked at. So you have folks looking at the models, and then you have folks looking at how that's going to be fleshed out and what that constitutes as well. Wow, we're barking.
Not sure. Doesn't like this corner or something, or maybe I'm supposed to stay put. Uh-oh. Now it's better. So there is a report. If folks haven't seen it, we can get that out to you. It is available for folks to look at, the report from Delaware. It's been out to some of the work groups, and so you do have things going on here to be talking about.
If people go on the Department of Health and Mental Hygiene website, there's a specific integration, behavioral health integration section, and it lists that report, it lists all the work groups, it lists opportunities to have input, it's all there.
I wanted to know, I saw Rhode Island was doing adolescents. Are there other programs that are actually doing health homes with children and adolescents?
As far as I know, they are not large in number. But there are some that are some states that are trying to do it. The reason Rhode Island can consider doing it is that their state is organized differently. They have a child section and an adult section. Delaware has a similar kind of situation, or has had, children and adults in separate sections. So they've been able to focus on adolescents, and for those of you who are interested in that, I would grab their model. I would go on their website, the state of Rhode Island, and take a look at what they're doing, rather than try to reinvent the wheel.
Actually, the whole medical health home model started in pediatrics. If you go to the American Academy of Pediatrics, to their website, they have a toolkit for doing behavioral health and primary care for kids. And when I first started looking at this back in '95 and used the internet, everything, all the literature, the first sets of literature are out of programs in pediatrics and kids programs. So absolutely, this is where it started. So moving forward. So other things, concerns. Everybody's like energized and ready to go do this. You have no concerns, nothing you want to talk about related to what this means for you, your organization, and the work. Oh, we have a hand in the back. Okay.
I had a quick question. I noticed that when you've had the chronic diseases listed up there, there were things like obesity, diabetes, asthma. Are those things limited to those specific chronic diseases? Because I didn't see anything like autoimmune disorders or anything like that listed on there. Autoimmune. Well,
So the question was, on the Affordable Care Act, the chronic diseases that qualify for a health home, she didn't see anything related to autoimmune. As the amendments come in, the Affordable Care Act does allow states to identify other chronic conditions. Those were just samples of what you could do, but you can identify other chronic conditions and include them in the application. It's available to do that.
As I mentioned yesterday, go if you have a chance, go on the NQF website, National Quality Forum, which is www.qualityforum.org website, and look at their framework for treating multiple chronic conditions. It's a wonderful discussion of what the issues are, about how you identify, what you need to identify, and what a framework for you to start thinking about what that means.
Anyone else? Questions, comments? Okay.
Well, just on a practical basis, is we're working on our integration project to do primary care, and now we're trying to figure out some things on the addiction side too, is we've been losing our shirts in outpatient mental health services for years. And then when we try to work with the federally qualified health center, they give a much higher rate, but we can't access that rate. So there's a legal regulatory barrier to certain kinds of mergers or partnerships. And then the whole issue of the shared information. So it all sounds exciting, but there's a huge number of practical problems built into the system. So who's doing anything to change that?
The Center for Integrated Health Solutions has been working on that. We have been able to work out ways in other states through partnerships and contractual models for behavioral health organizations to access the FQHC rate if you're under contract with them or if your staff work for them. You're nodding yes. Do you want to talk about that? Or if you can, yeah, because I think that is a key issue. folks identify it as a key barrier, but you really can, in partnership, build. So we'll have our FQHC CEO talk with us.
Ultimately, at the end of the day, it comes down to playing nice in the sandbox. And you know, that's a very elementary way to look at it, but that's really what it comes down to, is that everybody needs to be willing to partner. So if you're trying to work with an FQ who's not willing to share revenue streams and things, you're always going to run into a problem, and that's any business model. What we do is we subcontract. So I can subcontract a behavioral health provider at a rate that's higher than what you would get reimbursed, where I still can make a percentage profit as part of that contract. And it's twofold. It allows all of the patients to get serviced, and it allows an equal process for access. And ultimately, at the end of the day, FQs can't meet the demand for behavioral health, and that's really what it comes down to. It's not a competition in any stretch. The workforce just isn't there. And in the FQ, we do primary care best. That's what we were set up for. We offer services within the FQ for behavioral health, but we can't meet the demand, so we're going to have to partner. And that's from the FQ perspective, it means we're going to have to break down barriers too. We have to be willing to partner, but we also need community agencies to come to us and say, we want to partner with you too. In years past, it's always been a competition, and that's where the trouble has been.
And let me add one thing to that. The other advantage of partnering in a subcontract relationship with an FQ is that they are part of the 340B program. The 340B program is a pharmacy program. When they talk about, and every single medication for mental health disorders and for substance use disorders is in their 340B program. Some of us who used to work in the feds made sure of that a long time ago. And they're much less expensive because the 340B program is a bulk buyer, and the rates are at Medicaid or below in some cases. So you need to think about that when you're thinking about your partnerships.
When you partner with us, you also fall under our malpractice, which if you're not aware of the Federal Qualified Health Center's malpractice, we fall under the Federal Tort Claims Act, which means that if anyone sues us for malpractice, you're actually suing the federal government. So when we set up contracts, we're protected. It goes to the U.S. Attorney General. So that's a huge bonus too when you look at malpractice and the issues that come with that under the Federal Tort Claims.
And I think you raised the key question here. Mady and I can stand up here and provide you all kinds of models and ways to go about doing this. At the end of the day, it's all about relationships. Everything is, just like our treatment is about relationships, and that's the key factor. Doing this integration is all about relationships, and as you said, talking with your FQHC and getting things in places to do that. So we're willing to help move forward. There was a hand here. Oh, sorry.
We do co-occurring pretty well, but we definitely do not have the physical health piece. Do you have to work together with FQHCs, or can you do it with any other private medical practice?
Well, the question is, do you have to do it with an FQHC, or can you do it with any medical practice? You can do it with any medical practice. In Washtenaw County, Michigan, where I did this, we had no federally qualified health center, so we did this with the University of Michigan's Academic Medical Clinic. We did it with private practices in our community. It doesn't have to be an FQHC. The advantage of an FQHC or a community health center is the financial benefit of sharing in the reimbursement piece, but you can do it with any medical provider that you want to do this with. In our grant program, 63% of the grantees are partnering with a federally qualified health center. The other, 37% are either doing this themselves, they're hiring a doctor to come in and provide primary care, and they're going into the business. Really huge leap. If you talk about taking a leap, that's a huge leap. Really recommend the partnering because it can come out much faster. And as you said, you have experts in primary care in your system. You don't need to learn that business unless you don't have to, or unless you have to.
Some of the specialty treatment programs, particularly some of the residential providers, have decided to bring primary care into the residential provider, and very smart business thinking open up the primary care clinic that they're bringing in for their own patients to the community. That is a business model change that's huge, but very interesting. Very interesting. And interesting to think about in terms of the revenue stream that it brings in. Eventually, some of those will become FQs, probably.
Other questions, comments, thoughts? Those lemon slices on your table are tempting you, aren't they? So. Okay, if there are no other questions, we'll go ahead and let them set up for lunch, and we appreciate again the opportunity to present to you, and have a good afternoon.